Today, we are going to discuss the anesthetic approach for patients undergoing adrenalectomy, along with the important clinical reasoning behind every perioperative step shown in this image. Adrenalectomy is the surgical removal of one or both adrenal glands and may be performed for conditions such as pheochromocytoma, Cushing syndrome, Conn syndrome, adrenal adenoma, or adrenal malignancy. From an anesthetic perspective, adrenal surgery is considered highly challenging because the adrenal glands produce powerful hormones that significantly influence cardiovascular stability, electrolyte balance, glucose metabolism, and stress responses. During surgery, manipulation of adrenal tumors can cause sudden hemodynamic instability, severe hypertension, arrhythmias, or even circulatory collapse. Therefore, successful anesthetic management requires careful preoperative optimization, controlled induction, vigilant intraoperative monitoring, and meticulous postoperative care. The anesthetic journey begins with preoperative optimization, which is one of the most important phases in adrenalectomy. Before surgery, the anesthesiologist carefully evaluates the patient's cardiovascular and respiratory status because many adrenal disorders produce major systemic effects. Functional adrenal tumors are especially important because they actively secrete hormones. In pheochromocytoma, excessive catecholamine release causes severe hypertension, tachycardia, arrhythmias, headaches, sweating, and episodic hypertensive crises. In Cushing syndrome, excess cortisol leads to diabetes, obesity, hypertension, poor wound healing, osteoporosis, and increased infection risk. In Conn syndrome, excess aldosterone causes hypertension and hypokalemia, which can predispose to arrhythmias and muscle weakness. Therefore, endocrine investigations become essential before surgery. Plasma catecholamines or metanephrines are evaluated for pheochromocytoma, cortisol levels for Cushing syndrome, and aldosterone with potassium levels for Conn syndrome. Among all adrenal tumors, pheochromocytoma requires the most meticulous preparation because intraoperative catecholamine surges can be life-threatening. The image highlights the importance of adequate alpha blockade before surgery. Drugs such as phenixibenzamine or doxazosin are started days to weeks before surgery to control blood pressure and expand intravascular volume. Once adequate alpha blockade is achieved, beta blockers may be added carefully if tachycardia persists. This sequence is extremely important because giving beta blockers before alpha blockade can produce unopposed alpha stimulation and severe hypertensive crisis. The reasoning behind preoperative alpha blockade is to reduce perioperative sympathetic surges and improve cardiovascular stability during tumor handling. Patients undergoing bilateral adrenalectomy or surgery for Cushing syndrome may also require steroid supplementation because adrenal suppression can lead to postoperative adrenal insufficiency. Once the patient arrives in the operating room, the next phase is induction and airway management. Standard monitoring including ECG, pulse oximetry, capnography, blood pressure, and temperature monitoring is attached. In major adrenal surgery, invasive arterial blood pressure monitoring is often established because rapid blood pressure fluctuations are expected. Large-bore intravenous access is secured, and central venous access may sometimes be required depending on the complexity of the case. General anesthesia with endotracheal intubation is considered the standard technique because laparoscopic adrenalectomy requires complete immobility, controlled ventilation, and airway protection. Induction must be smooth and carefully controlled to avoid sympathetic stimulation. Laryngoscopy and intubation can trigger catecholamine release, especially in pheochromocytoma patients, causing severe hypertension and tachyarrhythmias. Therefore, anesthetic agents are selected specifically to blunt sympathetic responses. Drugs such as esmolol, lidocaine, opioids, and deep anesthetic planes are commonly used during induction. Agents that release catecholamines or stimulate the sympathetic nervous system are generally avoided. For example, succinylcholine may be avoided in some situations because muscle fasciculations and sympathetic stimulation can worsen hemodynamic instability. Neuromuscular blockers are administered to provide adequate paralysis and improve laparoscopic surgical conditions. Controlled ventilation is initiated after intubation, and ventilator settings are adjusted according to the patient's physiology and effects of pneumoperitoneum. The image then moves into intraoperative physiological changes and management, which represent the most critical portion of adrenalectomy anesthesia. In pheochromocytoma surgery, manipulation of the adrenal tumor can suddenly release massive amounts of catecholamines into circulation. This can cause severe hypertension, tachycardia, arrhythmias, myocardial ischemia, or even pulmonary edema. Blood pressure can rise dramatically within seconds. Therefore, the anesthesiologist must remain continuously prepared with rapidly acting antihypertensive drugs such as phentolamine, nicardipine, nitroprusside, or esmolol. Continuous arterial pressure monitoring allows rapid recognition and treatment of hemodynamic changes. However, the physiology changes dramatically once the tumor is removed. Before resection, the circulation may be dependent on high catecholamine levels maintaining vascular tone. Once the tumor is excised, catecholamine levels suddenly collapse, leading to profound vasodilation and severe hypotension. This post-resection hypotension can be dramatic and prolonged. Management includes aggressive fluid resuscitation, vasopressor support with drugs such as phenylephrine or vasopressin, and careful monitoring of organ perfusion. The image beautifully highlights this transition from hypertensive crisis during tumor manipulation to hypotension after tumor removal, which is one of the defining anesthetic challenges in adrenalectomy. The image also mentions disease-specific intraoperative considerations. In Conn syndrome, potassium monitoring becomes extremely important because aldosterone abnormalities affect electrolyte balance. Hypokalemia may predispose to arrhythmias and muscle weakness, so potassium levels are corrected carefully before and during surgery. In Cushing syndrome, steroid management is critical because chronic cortisol excess suppresses the hypothalamic pituitary adrenal axis. After adrenalectomy, patients may not produce adequate endogenous cortisol, placing them at risk of adrenal crisis. Therefore, stress-dose steroids such as hydrocortisone are administered perioperatively. Another important aspect shown in the image is patient positioning. During laparoscopic adrenalectomy, the patient is commonly placed in a modified flank position. Proper positioning is extremely important because the surgery may be prolonged and positioning-related injuries can occur. The head and neck must be secured carefully, pressure points padded adequately, and dependent limbs protected to prevent nerve injuries. Special attention is given to avoiding compression of the inferior vena cava because impaired venous return may worsen hemodynamic instability. The dependent lung may also become compressed, increasing the risk of atelectasis and impaired oxygenation. Eye protection is essential to prevent corneal abrasions or ocular pressure injuries. The reasoning behind careful positioning is to minimize complications related to prolonged surgery and altered physiology. Fluid management during adrenalectomy requires careful balance. In pheochromocytoma patients, chronic vasoconstriction often produces relative intravascular volume depletion despite hypertension. Therefore, adequate preload must be maintained before tumor removal. Goal-directed fluid therapy is preferred using parameters such as stroke volume variation or pulse pressure variation. Excessive fluid administration, however, should also be avoided because postoperative pulmonary edema or cardiac dysfunction may occur. Thus, the anesthesiologist continuously balances preload, cardiac output, and vasopressor requirements throughout surgery. Pain management forms another major component of the anesthetic strategy. Modern adrenalectomy anesthesia emphasizes multimodal opioid-sparing analgesia. Instead of relying only on opioids, multiple analgesic techniques are combined to improve pain control while minimizing nausea, sedation, and respiratory depression. The image highlights TAP blocks and quadratus lumborum blocks as useful regional anesthesia techniques. Local anesthetic infiltration at port sites, intravenous lidocaine infusion, acetaminophen, NSAIDs, and low-dose ketamine may also be used. This multimodal approach improves patient comfort and facilitates enhanced recovery after surgery protocols, commonly called ERAS pathways. The final stage shown in the image is the postoperative phase and ERAS goals. After surgery, patients require close monitoring in the recovery area or intensive care unit, depending on surgical complexity and intraoperative instability. Blood pressure monitoring remains extremely important because patients may continue to experience hypotension after pheochromocytoma resection. Electrolyte and glucose monitoring are also essential, especially in Conn syndrome and Cushing's syndrome patients. Adrenal insufficiency must be recognized early because inadequate cortisol levels can produce hypotension, weakness, vomiting, hypoglycemia, and shock. Therefore, cortisol monitoring and steroid replacement become critical in selected patients. Postoperative pain and nausea management continue using opioid-sparing strategies. Early mobilization, early nutrition, and prevention of complications such as pneumonia, bleeding, and deep vein thrombosis form major ERAS goals. By minimizing surgical stress and encouraging rapid recovery, patients achieve earlier discharge and better overall outcomes. To summarize, adrenalectomy represents one of the most physiologically dynamic surgeries encountered in anesthesia practice. The anesthetic approach requires detailed endocrine evaluation, careful preoperative optimization, smooth induction, aggressive hemodynamic management, vigilant monitoring, and comprehensive postoperative care. Pheochromocytoma surgery particularly illustrates the extreme cardiovascular instability that can occur during adrenal manipulation and tumor removal. Successful anesthetic management depends on anticipating these physiological changes before they occur and intervening rapidly to maintain cardiovascular stability, organ perfusion, pain control, and patient safety throughout the perioperative period.